What the Study Says.
Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May.
Imagine this. One moment, you're just living life, maybe chatting with a friend, making dinner, whatever, and the next, a sudden, terrifying interruption.
Yeah, like maybe one side of your face just inexplicably droops.
Or an arm just won't lift, your words come out all jumbled, like your tongue got tied.
It's like a lightning strike inside your head, a brain attack.
Exactly. It happens in an instant, and every single second that follows is just a desperate race against time. Because, when it comes to your brain, time literally equals tissue.
It really does.
So today on The Deep Dive, we're cutting through the noise. We're delivering the essential and sometimes surprising facts about stroke.
Right. We've gathered the latest research, clinical insights, all of it.
And we're diving deep from its sudden causes to the cutting-edge treatments and that long road to recovery.
That's the plan. We'll break down what stroke actually is, look at its different forms, blockage versus burst.
How it's diagnosed so quickly, that critical race against the clock for treatment.
And the potential complications, too. But also, importantly, what the science tells us about prevention and recovery.
The goal is for you to walk away feeling really well informed.
Oh, definitely.
Okay, so let's unpack this silent attacker. At its core, a stroke is a medical emergency. It happens when blood flow to part of your brain gets interrupted.
Or, less commonly, when a blood vessel in the brain actually ruptures.
And it's crucial to understand there are two main types. They're treated very differently.
Differently.
The first, and by far the most common, is an ischemic stroke.
Right. That accounts for, roughly 80 to 87% of all strokes, something like that?
Yeah, globally and here in the U.S. So basically, most strokes are caused by a blockage. Think of it like a plumbing problem in your brain's blood supply.
And that blockage can happen in a few ways.
Exactly. You've got thrombotic stroke, where a clot forms right there, often because of atherosclerosis, that hardening of the artery.
The plaque buildup, yeah.
Then there's an embolic stroke. That's where a clot forms somewhere else, maybe the heart.
Off the heart, yeah, like with atrial fibrillation.
Right, and it travels to the brain, gets stuck in a smaller vessel.
And finally, there's systemic hypoperfusion. That's more of a general circulation issue.
Like a widespread drop in blood flow affecting the whole brain, maybe from cardiac arrest or a severe arrhythmia.
Right. Less common cause of stroke, but still important.
Okay, so that's the blockage type. Then what's the other main category?
The other 10 to 20% are hemorrhagic strokes. And this is where a blood vessel in the brain actually bursts. It bleeds.
A bleed inside the head.
Exactly. And there are two main subtypes here, too. First, intracerebral hemorrhage, or ICH. That's bleeding directly into the brain tissue itself.
Like a bruise forming deep inside.
Kind of, yeah. The blood pools and expands usually over minutes to hours, and it pushes on the brain tissue.
Okay. And the second type?
The other is subarachnoid hemorrhage, or SAH. Now, this one is often particularly dramatic. Well, SAH frequently happens when an aneurysm, a weak balloon-like bulge on a blood vessel ruptures.
Ah, okay.
And this releases blood directly into this cerebrospinal fluid. That's the fluid cushioning your brain. And it does it under arterial pressure.
So very sudden high pressure.
Incredibly sudden. The blood spreads rapidly, causing a really dangerous increase in pressure inside the skull. The weird thing is the actual bleeding might only last seconds.
Only seconds.
Yeah, but rebleeding is surprisingly common and often devastating if it happens.
Wow. That distinction between bleeding into the brain versus around it is huge for understanding the immediate danger. So stepping back, what's the global impact?
Well, it's massive. Stroke is the second most common cause of death and disability worldwide.
Second for both. That's staggering.
It is. And here in the U.S., we're talking about around 795,000 new or recurrent strokes every year. Most are first-time events.
Just huge numbers.
Huge impact. And there are significant demographic disparities, too. Lifetime risk is actually higher for women.
Really? Higher for women?
Yes. And Black and Hispanic Americans have a significantly increased risk compared to white Americans. For instance, the risk linked to intracranial atherosclerosis, that specific artery hardening in the brain, is nearly 6 times higher in Black Americans.
6 times. That really highlights where we need to focus public health efforts.
Absolutely. Targeted prevention is key.
Okay, so given that sudden onset you mentioned, recognizing the signals is critical for everyone, right? Not just us doctors.
Crucial.
You've probably heard the FAST acronym, but our sources really zero in on the 3 most predictive examination findings for acute stroke.
Yes. Number 1, facial paresis. That's the facial droop or weakness.
Number 2, arm drift or weakness.
And number 3, abnormal speech. That could be slurring, dysarthria, or difficulty finding words, aphasia.
Those are often part of a bigger assessment tool we use in the hospital, the National Institutes of Health Stroke Scale, or NIHSS.
Right, the NIHSS. It's an 11-item scale, scores severity from 0 up to 42.
And just to give people context, a score under 5 is generally mild.
5 to 9 is moderate, and 10 or higher is usually considered severe.
It helps us gauge the impact quickly and make those urgent treatment decisions.
Exactly. And that diagnostic process is all about speed. First steps are immediate checks. Vitals, blood glucose.
Right. Got to rule out low blood sugar, which can look just like a stroke sometimes.
Definitely. And oxygen saturation. Then neuroimaging. This is absolutely critical.
Because you have to know if it's a blockage or a bleed.
Precisely. The treatments are completely different, even opposite in some ways. A non-contrast CT scan is usually first. Quick way to rule out hemorrhage.
See if there's blood.
Yeah. Then specialized scans like CT angiography can spot a large vessel occlusion, a big blocked artery. MRI gives even more detail.
Like seeing the acute damage. And importantly, if there's brain tissue, we can still save.
Exactly. Identifying that salvageable tissue, the penumbra, is key for treatment decisions, especially for thrombectomy.
And what about the heart? You mentioned atrial fibrillation earlier.
Yes, cardiac studies are vital. And ECG, continuous heart monitoring, looking for arrhythmias, especially AFib, which is a huge cause of embolic strokes.
Those traveling clots.
Right. And here's an interesting thing. Patients with ischemic stroke often have underlying coronary artery disease, but might not even know it. No chest pain reported.
So the stroke is the first sign something's wrong with the heart.
It can be. And stroke itself can actually cause ECG changes, mimicking a heart attack because of the body's stress response, the autonomic surge.
Yeah.
So extended cardiac monitoring, beyond just the first day, can really boost detection of that hidden AFib, which helps us prevent future strokes.
That connection between brain and heart is so important. Okay, so we know how it happens, how to spot it. Let's talk culprits. Causes and risk factors. The good news is many are modifiable, right? You can do something.
A lot of them are, yes.
The big one, the most common and important stroke risk factor, hypertension, high blood pressure.
Absolutely, number one.
Research shows stroke risk climbs even when BP is just above 11/075. But managing it works. Lowering diastolic BP by just 5 or 6 points long term.
Can cut stroke risk by 35 to 40%. It's huge.
Huge. And severe uncontrolled hypertension is especially risky for those bleeding strokes, the ICH.
Much higher relative risk for hemorrhagic than ischemic stroke with severe hypertension.
Then there's dyslipidemia, unhealthy cholesterol. This one's a bit tricky, isn't it?
It is. High cholesterol is linked to ischemic stroke, especially the atherosclerotic type.
The blockages.
Right. But there seems to be an inverse link with hemorrhagic stroke. Lower cholesterol might slightly increase bleed risk, though the data is complex.
Interesting. Okay, diabetes mellitus, that about doubles the risk of ischemic stroke.
Approximately doubles it, yes. And the risk is even higher for women with diabetes compared to men.
And smoking. No surprise there. Strong link to all stroke types.
Strong dose-response relationship. The more you smoke, the higher the risk.
But here's the good news. Quit smoking. And that excess risk mostly disappears within, 2 to 4 years?
That's what the data suggests. A powerful reason to quit.
Absolutely. What else is modifiable?
Physical inactivity. Being sedentary, sitting too long, definitely increases risk.
Get moving.
Yes. And alcohol and substance use. Heavy drinking is a risk factor. Stimulants like cocaine, amphetamines are particularly linked to hemorrhagic stroke.
And heart disease itself, beyond AFib.
Oh yes, a major source of emboli. Having a recent heart attack significantly bumps up stroke risk, especially in that first month.
So many things we can potentially influence.
A lot. But we also have to acknowledge the unmodifiable risk factors. Older age, especially over 80.
Can't change that.
Nope. Race and ethnicity play a role too. We mentioned Black and Hispanic Americans having higher overall risk. Black and Asian individuals have higher rates of hypertensive ICH.
Sex also factors in.
Yes, men generally have a higher risk, but women catch up or even exceed that risk at certain ages, like 35, 44, and over 85. Family history, genetic disorders, those count too.
And these things add up, right? They compound the risk.
They definitely compound. And we should probably mention covert brain infarction. Silent strokes.
Ah, yes, the hidden ones.
Seen on imaging, often no obvious symptoms, but linked to cognitive decline and more severe artery disease. Probably much more common than strokes that cause clear symptoms.
A really sobering thought, which brings us back to that urgency. Time is brain.
Bruh.
It's not just a slogan.
It's the absolute truth in stroke care.
The immediate goal is reperfusion therapy, restoring blood flow to brain tissue that's struggling but not dead yet.
Exactly. For acute ischemic stroke, the main treatment is intravenous thrombolysis, the Clot-Buster. Drugs like Alteplase or the newer tenecteplase.
And the clock is ticking. You need to get it within, 3 hours?
Ideally within 3 hours of symptom onset. The window can extend to 4.5 hours for some eligible patients.
Though there used to be more warnings for that extended window, like for older patients?
Yes. Earlier trials had cautions for patients over 80 or those with very severe strokes or prior stroke plus diabetes. But newer evidence suggests it's often safe and beneficial even for some of those patients now.
And for wake-up strokes, where you don't know the onset time.
Specialized imaging can help select patients who might still benefit even outside those standard time windows.
And the benefit is clear. These drugs improve outcomes.
They do. Regardless of age or how severe the stroke is initially.
But powerful medicines come with risks. Bleeding is the main one here.
It is. The main risk is symptomatic intracranial hemorrhage bleeding in the brain that causes symptoms. It's higher with Alteplase than without treatment, for sure.
It's a calculated risk.
Absolutely. A risk worth taking for many patients to save brain function. And it's worth noting, much of the bleeding occurs in brain tissue already damaged by the stroke, so it doesn't always worsen the deficit.
What about tenecteplase, the newer one?
It shows promise, especially lower doses when mechanical thrombectomy isn't an option right away. Higher doses have had some mixed, even concerning results in certain trials regarding bleeding and outcomes. Still evolving.
Okay, so that's the Clot-Buster. What if the clot is really big, blocking a major artery? That's where the Clot-Grabber comes in. Mechanical thrombectomy.
Yes. MT has been a complete game changer for large vessel occlusions, or LVOs, mainly in the front part of the brain circulation.
And the time window is much bigger.
Much bigger. Up to 24 hours from when the person was last known to be well, based on imaging. And you can do it even if they didn't get the IV Clot-Buster, or after they got it, that's called bridging therapy.
And the key is imaging, showing that big blockage and brain tissue that's still salvageable.
Exactly. You need both. The LVO and evidence of salvageable brain.
And the results are pretty dramatic.
Oh, absolutely. Significantly higher rates of functional independence. One big analysis showed 46% independence with MT versus maybe 27% with just medical management.
That's a huge difference.
Huge. And it helps across the board. Older patients, severe strokes, it often lowers mortality too.
So how do you actually grab the clot?
Well, basically, a catheter is threaded up through an artery, usually in the leg or sometimes the wrist, all the way to the brain clot. Then a special device, like a stent retriever.
Like a tiny cage.
Kind of, yeah. It opens up, grabs the clot, and you pull it out. Or sometimes aspiration, basically suction, is used.
Incredible. Are there risks with physically pulling it out, like more bleeding?
Compared to just medical management for the same type of severe stroke, MT generally doesn't increase the risk of symptomatic hemorrhage or death, but bleeding in the brain can happen. It's seen in imaging quite often, actually, though frequently it's asymptomatic or just related to how bad the stroke was to begin with.
Makes sense. And through all this IV drugs, physical clot removal blood pressure is still vital.
Absolutely critical. Before giving the IV Clot-Buster, systolic BP needs to be below 185. Diastolic below 110.
Okay.
And after reperfusion, the goal is to keep it at or below 180, 105 for the first 24 hours.
You don't want it too low either.
Exactly. Aggressively dropping it can be harmful, especially if someone has long-standing high blood pressure and hardened arteries. Their brain's autoregulation is shifted.
Meaning their brain is used to higher pressure to get enough blood flow.
Precisely. So dropping it too much, too fast, can actually cause more ischemia in vulnerable areas. It's a real balancing act.
A delicate dance indeed.
Yeah.
Are there times when these powerful treatments are just not an option? Exclusions?
Yes, definitely. If symptoms are improving very rapidly on their own to the point of being non-disabling, or if the initial scan shows a massive hemorrhage already.
Obviously.
Recent use of certain blood thinners requires checking coagulation levels first, very low platelet counts, things like that. But, as we said, some things that were once considered warnings, like age over 80 or severe stroke, are now often considered okay for treatment based on newer data. It's always evolving.
Constantly learning more. So, okay, the acute phase is managed, but the journey isn't over. Stroke leaves ripples.
Absolutely. Medical complications are common afterwards and really impact the outcome. Dysphagia, trouble swallowing, is incredibly common.
Really? How common?
Up to maybe 78% if you use instrumental testing, and it's a huge risk factor for aspiration pneumonia.
Food or liquid going into the lungs.
Exactly. That's why formal swallowing screens are standard practice. They cut down pneumonia risk.
And pneumonia itself still happens.
It does, in maybe 3 to 10% of patients. Aspiration is the cause most of the time, and it leads to worse outcomes, higher mortality.
What else?
Urinary tract infections, UTIs, are also common, maybe 11–15%, often linked to bladder catheters. Fever is bad news too, associated with worse outcomes, potentially worsening the brain injury.
And the heart issues can continue.
Yes, arrhythmias, even heart attacks. And that fascinating thing where the stroke itself triggers heart dysfunction, Takotsubo cardiomyopathy, the broken heart syndrome, mimicking an MI but caused by the brain's stress response.
The brain affecting the heart directly.
Right.
Wow. Any other common ones?
Gastrointestinal bleeding can happen, especially in older patients or those with severe strokes. And unfortunately, falls and fractures. Falls happen in about a quarter of patients post-stroke.
A quarter? That's a lot.
It is, and about 5% lead to serious injury, often fractures on the weak side. Cognitive issues, depression, older age all increase that risk.
So facing all these potential challenges, what does the long-term outlook, the recovery, usually look like?
Well, the most significant recovery usually happens in the first 3 to 6 months.
Okay, that early phase is key.
Very key. Though some improvement can continue, sometimes up to 18 months or even longer for some functions. Milder strokes tend to recover faster and more completely.
And the lasting impact, disability.
Neurologic deficits like weakness on one side, cognitive problems, they persist in maybe 40–50% of survivors at 6 months.
That's almost half.
Yeah. Things like depression, needing help to walk, social challenges affect about 30%. And sadly, around 25% might need long-term institutional care.
It sounds like a very long, challenging road for many. How do we measure this recovery?
We use scales. The Modified Rankin Scale, MRS, is common for overall functional outcome. 0 is no symptoms, 6 is death. A good outcome is often defined as 0 to 2.
Okay.
The Barthel Index looks at activities of daily living, and the NIHSS score taken acutely also helps predict outcome.
Though the NIHSS might not capture everything, like going back to work.
Exactly. It's good for predicting recovery from the initial deficits, but less so for complex things like employment or full social reintegration. And this is, critical interventions matter hugely.
Like the treatments we talked about.
Yes, timely reperfusion, specialized stroke unit care, and really importantly, rehabilitation. Physical, occupational, speech therapy. They significantly improve outcomes.
When should rehab start?
Well, interestingly, very intense therapy super early, like in the first day or two, might actually be harmful for some, but later therapy, starting after that very acute phase, is definitely beneficial and essential.
Good to know, finding that right balance. Okay, let's shift to the most hopeful part. Prevention. Stacking the odds in our favor. Especially for someone who's had a stroke or a TIA, a mini stroke. How do we prevent another one?
Secondary prevention is key. First, antithrombotic therapy, usually daily aspirin or another antiplatelet, unless there's a specific reason for anticoagulation, like AFib.
Got it. Meds first.
Yeah.
Then lifestyle.
Absolutely paramount. Smoking cessation. Remember that excess risk drops significantly within just a few years of quitting.
Huge incentive.
Regular physical exercise. Moderate intensity, think brisk walking, maybe 10 minutes 4 times a week. Or vigorous activity, 20 minutes twice a week, whatever you can manage consistently.
And diet, the usual suspects.
Pretty much. A healthy diet, the Mediterranean diet, often comes up. Salt restriction, weight control, limiting alcohol, all important.
And managing those conditions we talked about. Blood pressure, cholesterol.
Crucial. Blood pressure control is non-negotiable long-term. And statin therapy for lowering LDL cholesterol. This is a big one.
Even for people with average cholesterol.
Yes. The SPARFILE trial showed a high-dose statin reduced recurrent stroke significantly, even in those without known heart disease, and with LDLs that weren't super high to begin with.
And newer trials push those targets even lower.
Right. The Treat Stroke to Target, or TST trial, showed that aiming for an LDL below 70 milli-GDL led to significantly fewer major cardiovascular events compared to a higher target of 90/110.
So lower is generally better for preventing ischemic events. Any downside?
Well, as we touched on earlier, there's that slight nuance. Very aggressive LDL lowering might slightly increase hemorrhagic stroke risk. But for most patients who've had an ischemic stroke, the benefit of preventing another clot-based event clearly outweighs that small potential risk.
A careful calculation based on the individual.
Exactly. And managing other things too, like obstructive sleep apnea, if present, or specific clotting disorders. It's a comprehensive approach.
Well, this deep dive has really highlighted the complexity of stroke, hasn't it? But also the incredible progress in treatment and, crucially, the power we have through prevention. Understanding the types, the risks, the therapies, it really is empowering.
It absolutely is. And knowing that prevention is so key and that our bodies, they often give us clues before something major happens, it makes you think.
It does.
So maybe the question for everyone listening is, what small, consistent health choices might you rethink today to help protect your brain for tomorrow?
That is a powerful question to end on. Thank you for joining us on this deep dive into stroke.
Thank you.
If you found this useful, please share it with others. And be sure to subscribe to What the Study Says so you don't miss our next exploration. Until then, stay curious and stay informed.